Du Bois County, one will find various health fairs throughout the year. Recently, VU Jasper campus hosted its first student-created health fair. We spoke with Assistant Nursing Professor Marianne Norris at that event.
With the mother breastfeeding, the mother smoking, the babies getting
Health fair has been a combination of efforts put together by the student body of the nursing classes that represent the Phi Theta Kappa in providing a community health fair, setting up different booths and tables that the community can come in and enjoy. Have had booths from the American Cancer Society.
been exposed to cigarette smoking. It's got a tumor on the one side, that's why it's not inflating.
There's booths from the La Leche League. There's plenty of information in here to give information on fire safety. Bone density testings and things like that.
Okay.
This is a pig's lung that's been exposed to cigarette smoking.
That one's a diseased one.
And yeah, it's a diseased lung. It's got a tumor. That's why it's not properly inflating like a normal lung should. You can't really see it, but you can feel it a little bit.
They were assigned groups that they had to pick a certain area of health that they wanted to cover, be it women's health, children's health, any kind of nutritional health, holistic health, spiritual health, and they actually developed their own projects and worked together, one from each area of the nursing classes. It's turned out really well. We've had a lot of participation by the community. A lot of students have stopped by. We've had lots of support from all of the area health agencies that have come to set up booths also.
This is your post-information sheet. Got information on it. I'll tell you about it.
The American Red Cross also was present at the Jasper VU campus to collect
blood. There's no substitute for blood, so we need people to come in so we can keep replenishing the supply as the need goes out. The need for blood of all types. Right now we are short on O positive, so that's a big need right now.
Okay.
And read over some materials, and then you're going to go through the history section, and that's where we're going to ask you some questions about your finger, check your iron, and then you're going to go in the unit, and it's kind of like getting a shot or anything, just a little stick, and then donate some blood and go to the canteen and get some junk food. It's pretty simple. So.
junk food.
Well, first of all, it's just a little treat, and then for doing it, but we want to get the fluids back in you, some sugar back in you.
Little stick.
Part of the reason for the testing and the history are there are certain people who cannot.
A case case-by-case basis, cardiac medications, that type of thing. But for the most part, blood pressure medicines, cholesterol, diabetics can donate. Most people can donate blood if they come in and try. So,
Okay, release your hand.
Doing fine.
For W.
Together, they're entertained, they have a great time on that track during those 24 hours to celebrate what they have done. At our celebration, our special guests are our survivors. A survivor and a caregiver are invited, and they get together with other survivors and talk and act as support for each other. There's entertainment. Celebration lap. And basically what that is all the survivors and their caregivers walk the very first lap.
Are lit around the track in honor and in memory of the people who are surviving cancer and the people who have passed away from cancer. It's a very emotional time. We encourage people to come down and see what's going on and to partake in the entertainment and the activities. We'd love the general public to come down.
That includes games and stuff for the
Yeah, we had this year, we had asked all the teams if they would be interested in this to provide an item for a silent auction, and we invited not only the relay participants but the general public to come down. Certificates, and we only expect it to grow in the future, and I think it was a very well attended event. To be such a generous and caring community. Our grand total for this year was $250,000, $1 million, and actually it was $252,152.78, and we are of all of our teams in the Du Bois County area. They have just gone over and beyond any of our expectations.
That because the people here care so much about fighting cancer. As you can see, obviously they do. Office for research dollars, and we do fund more research than any other nonprofit organization. We're only second to the government in funding research. And in the research that we have funded 33 Nobel Prize winners that have done research on cancer, have discovered things such as the pap smear, the majority of tests, the majority of breakthroughs in cancer are done by our researchers, because we fund cutting-edge research that a lot of people won't fund, and that's where a lot of the breakthroughs come. In research, it's kind of hard to define things clearly, but this part was an intricate part to this part, and so a lot of our researchers have been very intricate in getting that major breakthrough.
Right. Tamoxifen?
Tamoxifen was our researcher. And a lot of people don't know that, because I think we're maybe a little too quiet about what we fund as far as research. But we're very proud of the breakthroughs that we have done. The other part of it, 60%, then goes to programs and education and services within our area, and things like Hope Lodge, which is a facility in Indianapolis where patients can go there and stay free of charge while they're getting treatments. And we've had many patients from this area say enough about it, how wonderful it is to be able not to have to worry about that financial burden of staying there night after night while getting their treatments in Indianapolis.
Relay for Life is held annually as a celebration to honor cancer survivors, pay tribute
program, which is a program that gets people calling friends, family, neighbors, women ages of 40 and over, to remind them to get their mammogram, because there's no better way to prevent breast cancer than annual mammograms. We also have the Great American Smokeout.
Right. The Great American Smokeout is something that happens every year in November, third Thursday. And we try to educate the public, of course, about not smoking. And if you could stop that one day, hopefully we'll be able to stop for good. We also work with the schools at that time with a program called Smoke Screen. It's usually in the middle school areas to keep kids from, that's when you need to get them the most, because it seems that's when they start to form their opinions about tobacco. So we start them in on that one. We also work with the local hospitals with screenings, everything from prostate cancer to again, the mammograms, to try and educate the public as far as getting the screenings done. We are going to do a little push about colorectal cancer this year as well.
And then we have a program called ACS at Work, and it's a program we started about 2 years ago. And what that is we go into companies and make them what we call five-star investors. We offer them a full menu of cancer prevention and cancer-related activities that will help their employees stay healthier. Thus, insurance costs go down for the company, and we're able to hopefully prevent some cancers. So it's a really good program that we're expanding each year. We try to get more companies involved with that, and geared to each individual. It's not asking you to go out and do 400 push-ups or set-ups. It's asking you just to move more than what you move right now. And that may mean exercising at your desk, eating better, doing better things nutritionally. And we provide like all kinds of little pamphlets and things to teach them how to eat their fruits and vegetables, and how to make better choices as far as eating out and that type of thing. And then we also give them a little, it's kind of a little competition thing where they compete with themselves to see that they can, by the end of that 10 weeks, that they are a little more active than what they were at the beginning of the 10 weeks.
To help not only on the Relay Committee for next year, but for the American Cancer Society in general. We have so many different projects and things that happen throughout the year that we need their help all year, not just now. Volunteers are what makes the American Cancer Society great. We work hard, but we can't do everything. We need all the help that we can get, and we appreciate all the help that the volunteers have offered to do.
Anything that we do without our volunteers. They're the ones that make the things happen that we do. And the volunteers that we have had this year and in the past are some of the most awesome people that I have ever met. And I would very much like to thank all the volunteers that participated this year, not only the committee, but the participants, the team captains, the volunteers with Relay, because they did an outstanding job.
For WJTS 27 Minutes, this is Tony Frick.
You can see how it's smooth. These little dark spots are just the blood vessels kind of tortuous coming towards the camera. We're looking at a three-dimensional object in a two-dimensional format, so it makes some of this look kind of unusual. But these are
In 1994, Memorial Hospital began offering diagnostic catheterization.
It is almost as smooth as the catheter right here. So no blockage.
In July of 2000, services offering angioplasty and coronary and peripheral arteries as well.
However, only occurs about 5% of the time. The majority of the time, 90+%.
The diagnostic tests of catheterization became available. It has become apparent that the sooner we can open an artery that's blocked, the more likely a person will do well. It's not a hard concept to understand. For example, if I put a tourniquet on your leg and didn't take it off for 10 hours, you're going to lose a lot of muscle. But if you put a tourniquet on your leg and take it off in 5 minutes or 20 minutes, you're going to save a lot of muscle. And that's the whole problem with what we're looking at here is blockage, and usually the final step to a blockage is a clot, and if there's some way we can get that clot open, and open up that vessel, we can save heart muscle. The name of our point where all the tests support the sooner we can open the artery, the better we are.
One thing we did with our floors, you see the little blue difference. The reason for that is the swing of the systems. Minimum of 3 staff involved. We always have a rad tech that's going to be working right side by side with the physician, and then 2 nurses that are always going to be involved. A nurse that's circulating in the room and a nurse that's actually functioning in the monitoring device.
Adam, they're people that started, I think 3 or 4 of the nurses started with me in ICU in 78 or 79. And they have grown in cardiology just as I have grown. And we've kind of all learned together. We're not new there. So they're nurses who, unlike many centers where I've trained, they know nursing, they know ICU. I think 3 or 4 of them do echoes, which is and now they've worked intensive care units. They understand the heat. Unless you're in the business, you don't realize this. I don't know what analogy to make, but they understand the hemodynamics of the heart, and that makes the whole crew really a strong group.
off. We did actually a lot of networking. I actually had 2 staff that went up to Green Bay, Wisconsin, and actually visited a hospital very similar in our size, doing the same thing that we're now doing. So we were able to pick their brains, see what worked for them, what didn't work for them. We actually visited our sister hospital up in Illinois, went up there, and actually Dr. Lempuler and Carol Alsman and one of our rad techs and myself, we flew to Houston to look at equipment down there. So we've actually had done a lot of work with it. Educating our staff, starting March 1st, all of our staff were actually routed off-site. Deaconess and St. Mary's were wonderful to work with us, and each of our staff members spent 3 weeks of intensive training. They already knew how to do diagnostic work. They were now learning how to do interventional work. So each one of them spent 3 weeks off-site. And then in-house, we did a remarkable amount of education. Dr. Lempuler actually did education when he returned also, but prior to that, we actually had staff out to some other seminars, but we did a lot of in-house with consultants coming in, some of our own staff doing research and educating, and then tried to think of everything possible that we could be presented with, and then try to look at that. We work with St. Mary's and Deaconess, as Dr. Lempuler said. We actually do have in place an emergent transfer scenario, and we've actually tested that transfer scenario. If we have somebody that we need to get out the door quickly, we've got that in place, and we've actually done trial runs with that so that we could figure out where does it work well, where it didn't work, and what do we have to work out, so that we've tried to cover all of our bases. Involved in that, and having people that have a medical care background just allows things to go smoother.
For
having a heart attack, that may be shortness of breath, or they may have been passed out, or may have had like a cardiac arrest somewhere and were brought in. They will do an EKG, and there are definite criteria, just like for using the blood clot dissolving medicines, to bring the patient urgently to the catheterization. So they do that. And what I usually do is, we respond quite quickly anyway, but I even have them, if they're unsure or they want to make sure that they're interpreting the EKG correctly, I have them fax the EKG to my house quickly, so that way I can see firsthand what it is, because a picture speaks 1,000 words a lot of times. There's some reassurances that they're having a heart attack, and that the criteria on the EKG suggests that their benefit comes from having urgent intervention. The cath lab staff is called, and they come to the hospital. We fire up the cath lab, get everything ready, get the patient over there. In the meantime, while they're in the emergency room, they'll be getting medications such as aspirin, because of the enormous benefits of aspirin. Nitroglycerin to help relieve some of the pain. A lot of times their blood pressure is extremely high because of all the duress that they're under. There are certain medicines called beta blockers. They block adrenaline. Obviously, your adrenaline would be rolling pretty high at this point in time when you're having a heart attack. And then they start them on a blood thinner, maybe something like a liquid aspirin, so to speak, called Integralin, or heparin, which is another type of blood thinner. Prepared for their catheterization, our staff is coming in, and I'm coming in and we're getting things together. What we do then is we get them to the cath lab. It's a sterile procedure, so we prep their both legs over the arteries in both legs, and then we go ahead and get the catheterization done. That's the diagnostic procedure first. That was kind of the part that you saw where we were looking at the left heart arteries and because the way things are laid out out on the table, the way the patient is laying there, and the way the equipment is laid out. It's a large enough vessel, it's easier to hit with the needle and things like that. You can use arteries off the wrist or off the bend in the arm if you need to. If they have like known blocked arteries or problems below, you can use the left if the right's blocked up or something. But that's the way to get your access to the heart. And then you go up with a catheter, which is a hollow tube, a soft hollow tube up to the heart, and you place it in there's essentially two coronary arteries, the left and the right, and you take pictures at your discretion, one or the other. I may choose to do, if it looks like on the EKG that the right heart artery is the one that's the problem, as in this last case, I go ahead and take some pictures of the left. I don't want to start working on the right till I know what the left looks like, because if the left main artery is blocked, that's the short segment before all those multiple branches. If that's blocked, that's a surgical issue, and that's not a time to be, doing something like that. That's a time to be shipping them off to someone else.
Because if they would blow up a balloon here, he would basically cut off all the circulation to the left ventricle. But if not this small vessel's obstructed, say it's one of these or any of these branches, he'll do that. They just do not do balloons up here in what they call the left main coronary.
No, it's in the left system, but not the left main. The left main, left circumflex artery. So this is probably covering 2/3 to 3/4 of the heart muscle. So if you obstruct with a balloon the flow both through this blood vessel and that, because of where it comes off, it would shut off all circulation. But if you move downstream a little bit to say the left anterior descending or the left circumflex artery or any of its branches, then that's safe and that's reasonable to do those particular branches. Okay, it's only that very short segment, right, that comes out before it breaks off into these that you really, would not want to do. And about 5% of the time when we're just doing catheterizations on average, like someone came in, not in dire straits, but just kind of electively to find out what's going on. So it's about a 5% chance that you cannot do intervention. And we find out what the problem is and then start working. And that would be to try and get a wire across the blockage. These fine wires are about as thick as your hair, and try to, essentially get through the remaining channel there. It can slide through the clotted material, but it's very difficult to slide through the calcium and the scarred down stuff. And so try and get your wire down. Once you get your wire through, and that acts as a rail, sort of like monorail trains and stuff like that. It acts as a rail for you to slide your balloons across, and then you can slide your balloon into the area that's diseased and expand the balloon to high pressure and open up the blood vessel, and then you can stent it if you first, just because the stent will hold all the debris and clot against the artery wall, kind of scaffolding against the wall, so not much stuff washes downstream to plug up little tiny blood vessels downstream. And then after you're done, then you usually continue certain types of medications to thin the blood and take care of things. EKG not improving. He's concerned about the chest pain persisting, and he called Dr. Dawkins, who happened to be there.
The heart is a muscle, and oxygen-rich blood is brought to that heart.
The evaluation in order to not risk more muscle loss. This artery should come down and come down to the bottom side of the heart. There's a lot of blood vessel missing. The reason we don't see it is blood vessels don't show up under X-ray. It takes dye to fill the blood vessel, and without dye going through the blood vessel, it's causing no blood vessel to appear. And here's the call.
In July, Memorial Hospital extended their service.
Blood clot dissolving medicine wasn't able to penetrate the clot. These are just different views. We're just trying to assess, okay, what size stent do we need to put in here? Well, how do we need to treat this next?
Peripheral vessel to hold it open. It remains there to improve.
Completely finished with the procedure in 37 minutes. And the average, the national average, your goal is set at 90 minutes. You want to have the blood vessel opened up within 90 minutes of them getting into the cath lab or getting to the door of the emergency.
And Dr. Lundfield is usually working on the opposite side. He has a rad tech, one of my radiology therapists is with him, working side by side with him. And then there's another nurse out in the room actually basically circulating. He's able to actually see everything that's happening with it. And as you can see, there's a lot of stock because there are all sizes of stents from very tiny to bigger ones to different diameters.
Occurs, Director of Cardiopulmonary Services, Marty Bickwortmert, spoke to us about taking symptoms of heart attack seriously.
Standard that you have to be this % blockage before you'll actually go in and do the angioplasty or put in the stent.
It's going to depend on quite several things.
So you're talking 70% blockage.
The vessel's here, and it's got a 70% blockage, and that it's now dwindled in regards to its ability to supply. People that I'd rather you present to the emergency room and it not be anything than you stay home, because those first few hours are very critical, not only to try to get blood flow back to that heart, but you also have a risk of electrical instability where the heart can go into an erratic rhythm. And if somebody's not there that sees that or sees that patient pass out in that rhythm, death can ensue within about 6 to 10 minutes. So that in itself, it's not only we want to salvage heart muscle, is we want to offset and prevent the electrical instability or actually be a mimicker of those. And just you presenting me looking at you, couldn't tell you. We'd have to look at possibly doing an EKG, because that's kind of an electrical window into the heart, so it tells us what's happening possibly. And sometimes patients don't even have changes there, so then it's the other things. We look at maybe echocardiography. If the clinical presentation is such that we really feel this is a heart attack, they may very well go ahead and come to the lab, because remember, a diagnostic cath is that. It's a diagnostic procedure. It's not something that's going to fix something right then. It's a diagnostic procedure, so sometimes that's what we have to do. Other 75% need intervention. It means that they may be treated medically. You know, if they don't have enough blockage, they may get treated medically with medical management. Doesn't mean in the future that they won't need to be recathed again, and possibly at that time then their blockage may be such that they need an intervention, or those could be patients needing intervention of balloon or angioplasty, or a patient that needs open heart surgery.
Heart muscle?
Heart muscle. That's what kills people in the long run, is the loss of that heart muscle prevents the good pump, and those patients get into heart failure. It really markedly affects their quality of life. Risk factors, obviously smoking is the #1 risk factor. Cholesterol issues, inactivity. I mean, you see all the data out now today talking about the obesity of our society. That very much plays a part with it. So all of those are risk factors. Just being a man to a certain degree is a high risk factor, but women, once they're past menopause, come to those same levels, and that's one thing that's really understated in society, is we're trying to make women more aware that they are in fact open to heart disease, and that they do need to be aware of that because they tend to be undertreated.
The other things, the proper diets, the proper activities, the proper communication skills.
Absolutely. The more risk factors that you add together, the greater your risk in terms of heart disease. But it doesn't mean, I mean, you may only have, genetic history is also an issue. You have patients that have genetic history because of the genes that they have, that they may run high cholesterols, maybe they have a syndrome in their family that has just caused them to be problematic. And part of it, key of our diet, how we eat.
A couple other risk factors are hypertension or high blood pressure and diabetes.
For people to know what their blood pressure is, they really should know what their blood pressure runs. Get it checked yearly, because hypertension is really a silent killer. It really does have dramatic effects on the heart and the blood vessels.
Briskly. And this is just one chamber of the heart where the dye goes in. This catheter is coming through the aorta. You can kind of see the shadow of it. But essentially, the patient is having a heart attack to the bottom side of your heart.
For WJTS
injury there. At this point, it can be stunned. If it persists and time passes, it can be scar tissue and permanently damaged tissue.